I'm Dr. Anthony Cave. And years ago, I had a patient with a fungating mass on their breast from breast cancer. They came on the table for debulking surgery. And when they came on the table, they were very well composed. They weren't new to the operating room or the medical scene. But the moment they saw the oxygen mask that went over their face, they burst into tears. This wasn't a child, this was a grown-up who had a lot of experience in challenging situations. So what I do is, as you know, I ask everyone to evacuate the operating room, literally. Because in moments of such vulnerability, especially before the traumatic physiologic stress of surgery, the mindset has to be optimized. I asked everyone to leave. I asked her, what's going on? In fact, I didn't have to ask much at all because she said, doctor, I didn't have to be here. I didn't quite understand what that meant. I said, well, what do you mean, man? There's this large mass that has to be removed. They responded saying that it turns out they had been diagnosed years ago, and because of avoidance and denial and suppression, they had not followed up with their chemo, and the mass had grown and grown and grown, despite it being diagnosed such a long time ago. So the heartbreaking part of this story is what led somebody who was so intelligent to leave their mass untreated and let it grow and grow. And it turns out that at least in part, it was due to how the diagnosis was made and what, I'm not blaming the doctor per se, but how that interaction of diagnosing a life-threatening condition has on the human psyche in ways that not even doctors are trained about in medical school, in fellowship, in residency, because that interaction is what colored, in part at least, this patient's trajectory. So this live stream today is about how impactful that initial conversation is and what you patients can also appreciate to prepare yourself in such interactions. It's not just cancer. It could be follow-up from a neurologic problem like a stroke, or a neurodegenerative problem like Parkinson's or ALS. It might be diabetes or heart disease. Anything can be bad news for any individual. And it's hard enough as is. The doctor or the healer's job is to help lessen that, to help grease the wheels of your inner healing potential. And it lies in the delivery, because the delivery matters. What they don't tell us in medical school, I did not know this. Nobody ever told me that what and how is said to the patient will determine or can influence their compliance with medications, like with chemo in that patient. Their anxiety for months and maybe years to come after the diagnosis is made. It can influence their emotional engagement or their emotional disengagement. And we all know how emotional disengagement can lead to loneliness. Loneliness in, quote, normal people like yourself and myself can have disastrous consequences. Now imagine loneliness when someone already has a serious condition like cancer, a neurodegenerative condition, etc. The satisfaction of a patient from their healing experience and even their pain control. It's like, when they say don't judge a book by its cover? Well, we do judge books by their covers. First impressions matter, and the first impression when a diagnosis of such severity is made can absolutely affect your mind and body for months or years to come. That patient was a real human being, an intelligent individual whose whole life had been upended. And the delivery, she felt, was partly the reason. So there's three things that we're going to talk about. One is the emotional reflex that patients and doctors have when delivering bad news. Number two is the ignorance is a bliss mentality, which is very pertinent to this. And number three are some strategies that at least doctors need to know. Number one, the emotional reflexes. Human beings cannot process complex information when they are overwhelmed by emotion. When you're emotionally overwhelmed, patients tend to respond in stereotypical ways to their doctors. The doctor will share something, and then the emotional response is to ask a question. A knee-jerk response is a question like, am I going to die? This is something that doctors need to recognize, that when they have set up the right environment, which we'll get to in number 3, the right setting to disclose and share bad news, when somebody reflexively responds to the question, you need to not answer that question so much as recognize the emotional burden that they're undergoing. Just like Linda is sharing about functional neurologic disorder, same thing. And Linda, I really appreciate you sharing your story with so many others. So if they say, am I ever going to get better? Am I going to die? Is this chemo going to make all of my body deteriorate? You don't need to answer the question, but ask and recognize where it's coming from. Yes, you can answer the question eventually, but we're not going to remember so much that complex question of the statistics, the prognosis, the probabilities, etc. Next is that patients, and I really want to know what you think, so please let me know here or let me know below in the comments. Patients don't like overly empathetic doctors. There's a fine line between empathy and pity. They almost have the same letters, they share a lot of them. Empathy and pity. Pity is like, oh, you poor thing. You don't know how to take care of yourself. You don't know how to interpret this information that I'm sharing with you. Let me do it for you. That's not something that helps build hope. And that's the hallmark that we're going to get to of how to deliver bad news. Not unfounded hope, but ultimately encouragement, factual hope. A Kruger's Cub. Thank you for that super thanks as well. And a saddle pulmonary embolism. I am so impressed that you made it on this side. We can talk about your story as well. I'm just so grateful that you made it past a pulmonary embolism. That's unbelievable. Oh my gosh. Thank you for sharing that at Kruger's Cub. So overly empathetic or overly sad and sappy turns patients off. I really want to know what you think, but this is what the very sparse data in the medical literature shows about how doctors should talk with patients. Just like Linda is saying, she hates pity, she wants kindness, compassion, which is so different than coddling and pity. Katie Johnson, good to see you, and she says, depends on the patient and their upbringing and personality. I prefer tough, hard news first, others want it at the end. This is really important, and we're going to talk a little bit about the variety, especially in Asian cultures and Western cultures. And Irene, good to see you. Barbara, I agree with all of you. Zatasha, very good points. Thank you. So lastly, before we move on to the ignorance is a bliss, which is what you guys are talking about, for the emotional reflex, doctors like to touch patients. And sometimes it's appropriate. You know that doctors like to touch joints, usually the shoulder and knee and elbow. Those are less threatening than touching someone's, face, their chest. Like, it's kind of awkward to touch those places. But an empathetic touch, several studies show, is not as well appreciated and well received by many patients. I'm curious what your views are as well. But there's a tendency for doctors to begin to get overly sappy. At least one study looks at about 40 seconds of sorrow or empathy is what patients like. It's almost like a sweet spot, at least in that one study. The reflex of patients and doctors are going to be quite different, and that's some of the expectations that one can have, and hopefully not fall into those traps. Number 2, the ignorance is a bliss. Many individuals in medicine used to think that it's best to guard information and not disclose the ugly truth to patients. Maybe let their families know, but not let the patients know. This is kind of an old school thing from the 20th century, early mid, where there's kind of like a doctor-patient relationship of a top-down or a, if you will, a power dynamic, as opposed to more of a flat, empowering patient advocacy, we're working together type of relationship. A lot of evidence and certainly cultural norms have gone towards more of a flat approach, and that's what we're going to talk about. What's called a patient and family-centric approach, where it takes into account the patient's spiritual beliefs, family values, religious views if they have them. And that involves, of course, giving the information, but in a contextually appropriate way, which means bring a loved one with you if you're a patient. It's so hard to receive challenging news And bad news, even if you're alone, right? Especially if you're alone, if you can bring a trusted family member who will be able to not only remember the discussion better with your doctor, advocate for yourself, help ask more questions. I personally always encourage a loved one to be present as well. Donna, thank you for that super thanks. I really appreciate it. Now, yes, Sabrina is saying patients are so different, and you're absolutely correct. This is why I'm sharing general trends. A big one is with Asian cultures. At least historically with Asian cultures, there is a stigma around terminal diagnoses. The thought, at least in some cultures around the world, even here in the United States, is that if we worry the patient, they are more likely to commit suicide out of hopelessness, despair, losing hope, etc. And when we guard that information from patients, of course, that doesn't give patients the autonomy and the knowledge that they deserve, and that appears to have changed, but we got to recognize that some cultures around the world will have the family know the prognosis and prevent or guard the patient from knowing that. Ignorance is a bliss. In some cultures, the problem is that the human brain will try to fill in gaps. They're called cognitive distortions. When the human brain does not have all of the information, it will start to make up, or it will start to what we call confabulate stuff. Now, Mary and Hope, please don't take this wrong. Not all Asian cultures, but it has just been documented in literature that some of those cultural norms try to destigmatize, or they have a stigma against how the individual will interpret challenging news or bad news, and they want to perhaps overcompensate and protect. I'm not saying that's right or wrong, but I'm saying that that is how doctors need to know how certain family values function and how certain family structures are going to operate. Now, number 3 are some basic strategies that everyone should be aware of. And there's so many of these online, and they vary in their success with patients significantly. You can look up SPIKES, S-P-I-K-E-S, online. SPIKES has a ton of, SPIKES is an acronym for a technique that has a lot of data behind it, but I want to share with you specifically some things that I like to share with others when they ask me how I deliver bad news. One of them is that it's got to be in an in-person setting. Telehealth is so popular these days in a post-pandemic world, not appropriate. Telephones, not appropriate. Like Lisa B says, hands off. I don't disagree. I think that the empathetic touch depends on the patient. It could go into too far of an empathy, sorrow, pity party when someone is in person with their doctor. Has to be a quiet environment, obviously, and most importantly is having time, because it turns out that it takes some time, often in quiet, for that information to be absorbed when it's given, after the right amount of understanding by the patient has been established. So the questions that doctors should ask in some shape or form is, how much do you know about your heart condition? Or how much do you know about the biopsy that was done of your breast or your liver? How much do you know about the results of the stress test that you did? Whatever it might be, you have to first gauge the patient's understanding or the family's understanding so that you give a contextually appropriate medical diagnosis. Not slamming them with jargon, because jargon will throw anyone off, but by recognizing that you have to give an age-appropriate, culturally appropriate, medical education appropriate, etc., explanation, and give them time, because they're going to have questions. But so often in this broken healthcare system, we rush patients through like it's a meatpacking factory. And if you don't have the right time, well, again, you got to make the time if you're the doctor, because the patients deserve to have that time to ask questions after the first bit of information has been shared and had a chance to sink in. I can't stress enough about asking the patients how much they might want to know, because some individuals, like others, like I think Sabrina was saying earlier, there's so much variety, so much variation in what patients want. Some patients want a fire hose. They want to hear it all and lay it on me, doc, all at once. Some patients want it to be in baby steps. None of them are right or wrong, but at the end of the day, this is what matters. If you hear nothing else, delivery matters. Honesty, encouragement, and hopefulness are the 3 traits that seem to appear time and time again to help patients be compliant with follow-up treatments, to help minimize the risk of anxiety from this, like the story we started off with, to help improve our chances of adequate pain control, to maximize the satisfaction with what's going on. You can have a bad diagnosis, but if you don't have life satisfaction, fulfillment, purpose, etc., it will make that diagnosis so much worse. And the flip side, with an unfortunate diagnosis, optimizing satisfaction, fulfillment, presence, connection with others is sometimes more valuable than the actual diagnosis itself. I hope that you appreciated. These are me responding to your questions that you want answered in the polls. If you've learned something, do please share it with others. Remember that you have more power over your health than you've ever been told. Whether you're a patient or a doctor, there is so much to learn about the art of medicine that makes the science of medicine so much more powerful. And I really appreciate Katie Johnson reading my mind about the art of medicine, the art of consciousness. It's so powerful to the healing profession, and I hope you all can help share this with someone else to empower them to advocate for themselves. If you could hit that like button, you appreciate me coming on here after a long day in the operating room. Your support helps me do these live streams more often, and I really appreciate it. Linda, thank you so much. You're absolutely right that Go See Mental Health is not an empowering way to gain the trust and facilitate the healing of a patient. I'm so sorry you've had those types of experiences, Linda, but I hope that with this community you're appreciating just how much we can leverage our mind-body connection to heal both the mind and the body, and not neglect one or the other. A broken body can't really heal a broken mind, and a broken mind can't heal a broken body. Until next time.